Okay, Bismillah. So I'd like to thank the Abstract Committee for accepting our poster. So I'll be presenting it on behalf of the team. The efficacy and safety of growth hormone therapy in childhood SLE. So as a background, we know that childhood lupus have long-term consequences. So the survival rates have improved. We have talked about that yesterday. Owing to the advances in the management. This was coupled with the uncovering of the long-term complications, including the growth delay up to 30% of population. And there was a study by Prof. Mayouf and adult colleagues in Saudi Arabia, up to 50% of patients will have growth delay and short stature. So contributing factors could be due to modifiable and non-modifiable factors. The modifiable factors include the glucocorticoid doses, disease activity control. Non-modifiable factors will include the gender, like male gender, lupus nephritis, and the disease severity and age of onset. Now, possible therapeutic intervention, we know that in short stature is growth hormone therapy. So patients with childhood lupus are not different. They do need physical and psychological support, including the short stature therapy. However, there's a special consideration in childhood lupus, the bidirectional relationship between lupus and growth hormone. So first, SLE by itself can suppress the growth hormone axis, which leads to growth hormone deficiency and short stature. On the other hand, the growth hormone itself was found recently to play some role in the etiopathogenesis and severity of the disease. So the aim was to evaluate the current evidence of the efficacy and safety of growth hormone in childhood SLE. Now, the search methodology was based on the PRISMA guidelines. The search was conducted last year, September and October, of the studies from January 1988 to October 2023. And we chose that duration because the studies in growth hormone therapy and rheumatic diseases was around that time in GIA initially. So we searched the electronic databases, including PubMed, Cochrane Library, and Web of Science. We included all articles in English, all children or pediatric patients with SLE who were treated with growth hormone at any dose with or without growth hormone therapy. So because of the limited or expected limited data, we included all case reports, series, cross-sectional studies, cohorts, and reviews. However, we excluded viewpoint articles and incomplete articles or non-English literature. So the search terms or MISH terms included anything that will indicate childhood lupus or pediatric SLE or juvenile SLE, as well as growth hormone therapy trade name, scientific name, or any MISH term for growth hormone therapy. So two independent reviewers screened initially the studies by the title and then by the abstract. Then full text of the citations were examined by both reviewers. Any disagreements regarding the eligibility was solved by another third reviewer. So full text articles were screened, and further, references list of the primary articles were searched for additional studies in these references. Moving to the results, so we identified initially 8,191 records from those three databases. Out of which 1,800 plus were excluded or removed due to duplications. And we screened initially by the, as I mentioned, title, then abstract, 6,364 articles. Out of these articles, we excluded 6,343 articles due to irrelevance, wrong population, drug, no intervention with growth hormone therapy. We ended up with 21 articles for retrieval. Out of those, we could not retrieve one article because it was an old study for a single author. It was case report. We tried to reach that author, but there is no response. The other was in Portuguese, so it was excluded. So we ended up with 19 reports eligible for the full assessment, and out of those, we excluded 12 due to no treatment, wrong medication, and wrong population. So we started with 8,000 plus, we cut it down to 6,000 plus, and then 19 reports were assessed for eligibility. Out of those, ultimately, we ended up with only 2 articles that were eligible for the study. So these were only case reports, long time ago. So one was from Korea, 2001, the other was from Singapore, 1998, so this was 2 decades back. Both were males diagnosed at the age of 8 years with SLE. Both had lupus nephritis, were in prolonged duration of glucocorticoid, and that is why they thought that they had short stature due to disease activity itself and due to the glucocorticoids. One of them, the first patient, had growth hormone deficiency with low testosterone. So the age at initiation was 16 and 15 years respectively. The height after growth hormone improved significantly. We're talking about 10 cm within 9 months and 2.7 cm within 4 months. However, the growth hormone therapy was discontinued because they had the flare manifestations. Both patients did not have clinical features. Both of them only had serological manifestations, and at that time there was no explanation for the flare other than growth hormone therapy, but this cannot be proven. Now, therapy escalation was required in one patient, the first patient. As you can see, there was increased dose of glucocorticoid and shortened cyclophosphamide intervals. Unfortunately, other side effects reported in growth hormone were not mentioned in these articles. So both concluded that there is a positive effect or potentially positive effect of growth hormone in childhood lupus. However, it might increase disease activity. Again, we cannot conclude that. So our study concluded that growth failure and short stature are known as potentially irreversible complication of childhood SLE, and patients do need therapy. We are not giving them therapy because of the severity of the disease, but we cannot still ignore that aspect. So this systematic review demonstrates the limited data. We did expect limited data, but not to the extent of 2 case reports 2 decades back only, and there's a gap after that. Reports in this study described a positive effect on linear growth, but with lupus flare, again, we cannot prove any of those with case reports. Further studies and clinical trials are needed to better understand the potential efficacy and safety of growth hormone therapy in childhood SLE, including different aspects. We do have some limitations in this study. So first, the language selection. There was one Portuguese study that we excluded, which also added to the limited number of data. The second limitation was the study publication and type. So again, these are 2 decades back and only case report. We cannot come up with solid and definitive conclusion for either the role of growth hormone therapy in the flare or the improvement in height. So there is a potential side effect of growth hormone therapy which has not been mentioned in these articles, metabolic side effects or other mentioned side effects on bone. Unmet needs in growth hormone therapy in childhood lupus. We do have some pre-therapy consideration, therapy-related, and long-term consequences. So pre-therapy consideration is the what is the optimal age for therapy initiation? Still, we do not know that. Second is there an accepted disease severity and activity before we initiate growth hormone therapy? Should we put patients in remission or disease activity? Still, there is no answer. And what is the accepted dose of glucocorticoid and lupus therapeutic, knowing that glucocorticoid will affect the bone metabolism and growth? The second is the therapy related. So what is the optimal dose and duration to continue growth hormone therapy? And will therapeutic interventions directed for SLE affect the response for growth hormone therapy? We know that the pathway of growth hormone therapy do interact with some of the medications that we're using. The third question is there a potential of growth hormone therapy counteracting our medications which will induce flares in lupus? And the final point, which is the monitoring and long-term consequences. So what should be the frequency to monitor patients for the clinical and serological activity? Should it be more frequent while we start growth hormone therapy or not? Second, are there any additional metabolic effect that has been reported, glycemic control, bone formation and resorption, especially that these patients are on glucocorticoids? And the final question is, what is the expected final adult height that we should be satisfied with? Is it the same as the normal population, or is it different for patients with lupus? And by that, I would like to conclude. Of course, I would like to thank the team for their amazing job. These are medical interns that did amazing work, and of course, Prof. Mayoub for his continuous support throughout. Thank you very much.
Thank you very much, Dr. Jane. Any questions?
Yes. Well, this is another idea, yes, but we limited that to SLE because of the deficiency that was expected. So GIA, there are studies in GIA, a huge amount of patients, not randomized control, not strong evidence to be honest. All of them are case report, case series. But we think that the deficiency is more in lupus patients, and we know that these patients up to a third will have short stature. but somehow we're ignoring that part because of the disease severity. So I think it's time to assess that medication efficacy and safety in lupus.
Thank you, Dr. Ali Jane.